I'm a fellowship-trained breast surgical oncologist. My name is Dr. Amani Jambakar, and I'm currently practicing in Santa Fe, New Mexico. Some members of my team asked me to explain atypical lobular hyperplasia. This is atypical lobular hyperplasia, which presents as architectural distortion on a mammogram. Architectural distortion means that there's something about the tissue that looks a little bit different, but there isn't a distinct mass. This is the other view of the same mammogram. Atypical lobular hyperplasia means overgrowth of the cells which are in the milk-producing glands or the lobules of the breast. This is a study which was published in the World Journal of Surgery in May of 2024, in which they looked at 125 patients with 127 atypical lobular lesions diagnosed via needle core biopsy at Cornell. Out of the 127 lesions, 75% were immediately excised and 25% were observed, meaning that the patient underwent more breast imaging in 6 months. In the patients who underwent excision, there were only 2 who were diagnosed with cancer, meaning an upgrade rate of only 2.1%. And in the ones who were followed, which was 32 patients, none of them progressed over about 2 years to anything that looked like it was growing or that it might be a cancer on imaging. The study concluded that there is no reason to excise atypical lobular hyperplasia and that it can be safely watched on imaging. This is atypical lobular hyperplasia on an MRI, and MRIs sometimes are recommended because patients who develop ALH are at increased risk for a future breast cancer, but they can be safely observed with breast imaging and do not need excision, and that's what the current guidelines from the American Society of Breast Surgeons recommend as well.